My talk is about differentiation. How can we be different from our competitors? How can we offer something that our patients only get from us? How can you be something special for your patient? And I think the best way to do it is differentiation through aesthetics, because everyone can align teeth. Nowadays, it doesn't even take a human being. Actually, the algorithms are so good already that they can align teeth, but you create a smile that changes the way someone feels about themselves, that they wake up in the morning, hair, whatever, but they look into the mirror and say, I like my teeth. They're beautiful. They make me beautiful. So there's so many things when it comes to aesthetics, and we can talk for hours, but I really boil it down to three very important things, three very important characteristics that make a beautiful smile. And this is the smile arc, so the gentle curve that is formed by maxillary incisors, the smile width, so that when people smile, we see the teeth, and incisor display. So we are going to talk about those three things, how we can achieve those. And just to explain a little bit, the smile arc. So the smile arc, the definition is that the incisal edges of maxillary incisors form a positive curvature that is ideally parallel to the contour of the lower lip. And you can see here that the teeth are in all different kinds of angulation and places, and there's a lot of disharmony in the smile. So there's a lot of visual tension. There's everything going in its own direction. And what we want to create is this harmony, this gradation, where the incisal edges follow this gradation of being a little bit shorter. So the incisors, the central incisors are the baseline, and then the laterals are a little bit shorter, the canines are a little bit shorter, and this progresses to the back of the teeth. Like this, we create harmony and a smile. And the smile is more pleasing to the eye. Here, another example. Also, the same, the smile arc is more like a wave. It's going up and down. And with aligners, even with aligners, it's possible to create a great smile and to transform the appearance of someone. We will also talk about the smile width. So basically, that means that we want to see the teeth in the smile. And here, you can only see canine to canine. You wouldn't know if she had teeth behind the canine because they're hiding. They do not get any light. So what we want to create is this gradation where each tooth introduces the next. And every tooth has his or its position in a smile. Like in a necklace with pearls, every pearl has its place, and together they form a nice, good-looking appearance. And we will also talk about incisor display. So in this patient, in her, we see 100% of incisors, but also a lot of gum tissue. So ideally, the perfect aesthetics are achieved when we have 100% incisor display and 1 millimeter of gum tissue showing. So in her, that's definitely more. We can say that she has a gummy smile, anterior and posterior. And not long ago, we would have treated that with surgery, maxillary impaction. And of course, most patients wouldn't want that kind of treatment. Then with the innovation of orthodontic mini implants, we could intrude the whole upper arch with braces and orthodontic mini screws. And today we can also do that with aligners. Here you can see that she still has her tat because we're still in treatment. And this is for me, this is mind-blowing, that we can avoid surgery and do that with aligners so that the patients enjoy the journey. But usually we're faced with the teeth hiding underneath the lip. So like in this patient, he's not showing 100% of incisors. He's showing just half of the tooth. And this has a great impact on appearance. So we're not showing 100% of incisors. This is related with aging, with an aged smile, with elderly people, because the lip has less tension, less muscle activity, and the teeth hide beneath the lip. So when we have the chance to change a smile, we want to have 100% of incisor display. So we covered the theoretical part, but how can we achieve that in our treatment plans? So this is why we're going to have a look at the first patient. This is Leonardo, and he has a very symmetrical face, very well proportionate. His smile is not bad, but there are a few things that can be improved. So when we look at the gum display, he has more or less a posterior gummy smile, and the smile arc is reversed. So posterior teeth are hanging down, incisors are farther up, and the incisal embrasures, they are all over the place. They're very disharmonious, and there's a lot that we can do. His profile is very straight, very normal, well proportionate. So the reason why he sought treatment is because he realized that there's a lot of wear going on his upper left incisor. And you can see the deep bite. You can already assume some crowding in the lower arch. And also note how narrow the upper arch is, how there's a constriction in the area of the premolars and first molars. Here's the picture slightly opened. I highly recommend to take this record because it shows you the incisal edges and the wear. And here you can see that there's a lot of wear going on in lower incisors. And when you look at the torques, in upper posterior teeth, the torques are straight. But when you compare it to lower premolars and molars, the inclination is very negative. So they're tipped inward. When we look at the right side, he presents with the class 1 in molar and canine, and you can see the deep bite. Deep bite is even more better visible from the left side. Also on the left side, he is a class 1, but deep bite, and you can clearly see the rotation in the upper left central. When we look at the upper arch, you can see this almost omega shape upper arch, and the rotation and the missing edge, the missing incisal edge of the upper left central due to the rotation and the excessive wear. Because when he protrudes, this is the place where all the forces go. So he protrudes only on that tooth. And in the lower jaw, you can see the omega shape is even more accentuated. So it's really a constriction in the posterior area and some crowding in the lower arch. The panoramic X-ray shows that he has predominantly healthy teeth. Here you can see the scout picture because I took a CBCT. I tried a little bit to work with CBCT instead of Ceph, but it turned out that a Ceph is very useful in the analysis. So nowadays I take the CBCT, ultra low dose, and a Ceph and a panoramic X-ray. So how can we achieve a great smile for Leonardo? Going back to what we want to achieve, I want to focus on the smile width. So we want to change the arch shape from this omega shape to a nice wide parabolic or ovoid arch shape. So for that, you need to expand And when it comes to expansion, it's important to look at the torques. So when we have collapsed arches, if there's negative torque, we can just upright it. Just upright the teeth and we get relative expansion. But if the torques are already straight, we need to do bodily expansion. And George, you told me you started with Spark 2 months ago. So what I really like about Spark is that you can see the roots. So it's easy to see the torque. It's easy to assess that. For example, in the premolars, in the fives, the second premolars, if you do not see the roots, the torque is straight. In the first premolar, you have 2 roots, so it's okay to see the palatal root. But when you look at the 7s here, you see the palatal root. So this tooth is slightly buccally inclined, and we do not want to expand the 7 even more. We rather expand the 6s and the premolars to get a good arch shape. So we kind of use here the 7s as the limit of the arch and expand to that limit. And here you can see how it was possible with the aligners to achieve bodily expansion, to change the arch shape, and create the smile width that we want to have, where we have this nice gradation where each tooth introduces the next. So for this bodily expansion, it's important to have attachments. We need horizontal attachments because it's easy with aligners, it's easy to move the crowns, but it's a little bit harder to move the roots. This is why we need an attachment for support. Here you can see how the arch is getting wider and we create this nice smile width. And you can see how bad the wear of incisors is once the teeth are aligned. So we definitely need to do some kind of restorative work here to create a nice and harmonious smile. And also note that I'm intruding lower incisors, because when we want to create this smile arc, we usually extrude upper incisors or retract in his case. And we need to create this overchat. So we want to achieve this overchat by lower incisor intrusion. Do not want to intrude upper incisors because that would flatten the smile arc. So lower incisor intrusion is very crucial. And here you can see the final picture after treatment, how it was possible to achieve straight torques in premolars, although we did bodily expansion. In the lower jaw, the expansion is much easier. If you look, the torque was negative, and we just had to upright the crowns to expand. And this is very easy with aligners. You wouldn't need any attachment for that. So let's look at the lower jaw again. Here we had this even more pronounced omega-shaped arch form, and we want to create this parabolic arch shape. And it was achieved by uprighting the molars and premolars, which is easy. That's really easy for the aligner. It gets difficult when we want to move the root. And here you can see the final picture of alignment and how it was possible to change the arch shape and create harmony in a smile. So coming to the biomechanics, we already mentioned that we need horizontal attachments in the upper jaw to ensure the roots also expand, not just the crowns. In lower incisors, we need the attachments for the intrusion. So imagine when the aligner wants to intrude lower incisors, the lower incisors exert a resistance. So the aligner wants to lift off from posterior teeth. And to hold the aligner in place, you need to place those horizontal attachments in lower premolars and also in molars. It's not a mistake also to place them in molars. The more, the better. So here you can see that the deep bite was improved. Class 1 was maintained. And the lower incisor intrusion was achieved through the assistance of the bite ramps in uppers, and what is most crucial, with the attachments in lower premolars. So here you can see it again, just from the upper side, from the left side. You can also see how I place an attachment in the wisdom tooth here. This is not necessarily to move the tooth, but aligners tend to misfit on the wisdom teeth. This is most likely due to manufacturing processes. So it doesn't harm to place an attachment here just to ensure good fitting of the aligner on that tooth. And this is the after picture. So this is how his smile looks now. And there's an incredible change. So we respected the smile arc, we created the smile width, and we made sure to maintain the 100% incisor display with lower incisor intrusion, not upper incisor intrusion. What you will often see in the simulation, and look out for that, when the technicians plan it and you want to solve a deep bite of, let's say, 4 millimeters, they will intrude uppers for 2 millimeters and lowers for 2 millimeters to dissipate the intrusion in both jaws. But this will flatten the smile arc if you intrude upper incisors. This is why we need to focus on lower incisor intrusion. This is why the attachments on lower premolars and molars are so important. And here is a comparison before and after. And you can imagine how happy he was with his new smile, that he really feels proud to show his teeth, and that he, is absolutely happy to have gone this journey to a new smile. And this is something that you do. You create smiles. You do not simply align teeth. You create a smile. So the lesson from this case is how to perform expansion. Remember, if we start with negative torque, we just need to upright the teeth. We just do buccal crown tip, which is so easy for the aligner. The aligner is covering the crown, and the force is applied where it's supposed to work. We do not need any attachments for that. That is really easy. However, difficult is bodily expansion, when we want to expand the crown for the same amount as the root. This is when you need a horizontal attachment. And it's not so important if the horizontal attachment is just rectangular or gingival beveled. The most important thing is that it's horizontal and not vertical. And the reason for the attachment is, so the idea behind it is, if we do not have this attachment, the crowns would just incline to the buccal, but we want to really move the root. So we give, with the attachment, we provide extra surface for the aligner to apply the force, to also bring the root with it, to apply this buccal root torque. So take home for you, bodily expansion needs horizontal attachment. This is really crucial. Check your case designs, have a look if there's just uprighting of the crowns or bodily expansion. When there's bodily expansion, place horizontal attachments. And now I want to dive a little bit deeper into the smile arc. So this is now your time to guess. Those designs really look pretty similar, but which one do you like best? If you had to pick one, which do you like best? Who is for the upper one? No one. No one. Who is for the left one on the bottom? No one. And the one on the right side?
Yes.
Yes, wonderful. So this is the design where the smile arc was respected, where we have this 0.5 millimeter increments between the centrals, the laterals, the canines, and they progress to the back. And studies have shown that this is considered as as the most attractive smile compared to a flat smile arc or an inverted smile arc. And this also gives a very youthful appearance, because imagine older patients, they usually, or older people, they grind their teeth and it's just flat. So flat is associated with more worn and more mature dentition. So this is the one we want to aim for. And it's pretty easy to get that. You can put that into your clinical preferences. If you go to your clinical preferences, just click the first button, smile arc, 0.5 laterals above centrals, etc. Okay, but it's so easy to get that in a software. We want to learn how to achieve that in a patient, because in the software, you can do everything. It's the biomechanics that make the software, the simulation and the software work. So I want to introduce the next patient. This is Ricardo. And what do you see when you look at his face? There are so many things to see. So many things that can be missed. So you probably now look at the smile arc. Is it a positive curvature that is parallel to the lower lip? No, it's the opposite. So it's inverted, which gives the smile a kind of odd look. When you look at the buccal corridors and the width of the smile, how does it look like? Looks very narrow, right? And what you cannot see here is that usually his head position is a little bit like this. So he tilts his head to the back. And you can also see that the tongue is placed between the teeth. So the tongue is not where it's supposed to be, it's between the teeth. And if I see something like this today, I would just ask a few questions about airway. So I would ask him, hey, has anyone ever noticed that you're snoring? Do you sleep well? Do you sleep through the night? And do you breathe through your nose? So especially during sleeping. And patients, of course, they do not know how they sleep, but you can also ask, is your mouth dry when you wake up? And if it's dry, it's probably because they're breathing through the mouth and not through the nose. And this is so important that we breathe through our nose. So his therapy also included logotherapy to train the tongue to be at the right position, not between the teeth, because whatever we try to do, the tongue is so much stronger than any appliance that we have. So his cephalometric analysis shows that upper incisors are very proclined. Also, the lowers are proclined. Looking at his panoramic X-ray, you can see the crowding. He still has wisdom teeth, which are planned to be extracted. And here's the intraoral view. So there are a lot of things going on. We already mentioned the constricted arches, the proclined incisors, and a negative smile arc. But you also can see this severe crowding and the severe midline deviation. Slightly open, you can see the curve of Spee, which is very accentuated in the lower and in the upper jaw. Right side, the canine is completely outside the arch, completely tipped forward. And it's also clearly visible how the upper incisors are proclined. Here on the left side, you can actually see the lingual surface of the canine in the closed mouth. So severe crowding, but class 1. Upper jaw, looks narrow, some crowding in upper incisors. Lower jaw, we have severe rotation of the lower premolar, severe crowding. The lateral and the premolar are almost touching. So how would you treat that patient? How would you treat that malocclusion? Patient had already seen some orthodontists before me, and they were looking for a solution without premolar extraction. And I was happy to do that. I try to keep teeth whenever it's possible. And I suggested to do bimaxillary distalization to provide the space to retrocline upper incisors, to expand the arch, and to give him a nice smile, because this is what he was asking for. He said, I really do not feel comfortable showing my teeth, and I would really like to like my smile. So here you can see the sequential distalization that was performed in the upper jaw. This is sequential distalization, probably 70%, so it's not 50% pattern. 50% would be that as soon as the 7 has gone 50% of the way, the 6 starts. As soon as the 7 is in final position, the 5 starts, etc. So in that case, I used TADs. I used orthodontic mini screws to provide indirect anchorage. So once the 7s were in final position, I placed a TAD, bonded the button on the 7, and put a ligature from the button to the TAD, because I really didn't want to lose any of the distalization during retraction. And this allowed me also to distalize more teeth simultaneously than just 2. So you can see how I created space through distalization and solved the proclined incisors by allowing space posteriorly and then do the retroclination. Here you can see the final result, how it was possible to change the torque, how the distalization worked beautifully, and the incisors are now in the proper inclination. So the good thing about proclined incisors is that we can extrude them relatively easy, because basically what we do in this type of occlusion and in this type of movement is we do a relative extrusion. So we change the torque. By changing the inclination of incisors, we perform this relative extrusion. So here you can see it better from the frontal view. The teeth distalize in both jaws, of course, because we started out with the class 1, want to end in the class 1, you need to distalize both jaws. And as soon as we have created the space, we can retrocline incisors. So by retroclining, we basically keep the apex of the root where it is and just retrocline the crown. And like this, we get this relative extrusion. Here you can see the after picture, how we were able to create a smile arc. We have the smile width, and we increased incisor display because we did a relative extrusion of upper incisors. And of course, the incisal edges were restored because they were so badly worn, and this was necessary. And of course, whenever we want to extrude upper incisors, we need to intrude lower incisors. So here we had this accentuated curve of speed, this deep bite, and lower incisor intrusion was planned to provide the overjet that is needed. And here you can see the movement of lower jaw. So also here I have this sequential distalization pattern. I reinforce it with TADs to provide anchorage. And in the premolar is completely rotated by 90 degrees. This is why I planned buttons and elastics to derotate it. because in this case, it wouldn't make sense to do a hinge rotation. So I opted for pure rotation, which means that the axis of rotation runs right through the middle of the tooth. And the more rounded the profile of the tooth is, the less good that works. So for premolars, a pure rotation hardly ever works without buttons. With buttons, it worked really nicely, really well. And you can see that I opted for vertical attachments in the molars and premolars to facilitate the bodily distalization. I do not simply want to tip the teeth backwards. I want to have this bodily distalization. This is why I need these vertical attachments to give the aligner extra surface to also move the roots. And here you can see the after picture, how the crowding was solved, how we achieved distalization. And before, the premolar and the lateral were kissing. Now the canine is in the right position. And actually, if you look, I started with a hinge rotation here. It's moving distal out. And then I continued with a pure rotation. Because the problem with the hinge rotation is that it is basically an expansion. And I didn't want to push the tooth too far outside the arch. This is why I just started with the hinge rotation, not to have the buttons right from the beginning, because it can be a little bit uncomfortable in the lingual side, and then continue with the pure rotation. So from the side, it looks like this. We have this bimaxillary distalization. Upper incisors are completely proclined. I allow to procline them even more just to get some alignment. And I do that to improve the treatment experience for the patients. Because I realized it's very frustrating when nothing moves for months for the patient and they only see canine to canine. They do not know and do not care about the occlusal correction that's happening in the posterior. They want to see some progress. So I want to give them some progress. This is why I started out slowly aligning upper incisors with reduced speed. And as soon as there is space, retroclining the upper incisors. And you can see that this is a relative extrusion because we're changing the torque basically. And this works really well with aligners. You can see here how it was possible to maintain the class 1, how there's proper overjet, overbite, and the incisors have a good inclination. Here from the other side, it's the same. We have the sequential distalization sequenced movement reinforced with orthodontic mini screws, and then gradually retracting upper incisors, changing the torque, and like this, do a relative extrusion. And through this extrusion, I improve incisor display. So more of the incisor is visible. Here's the after picture. So before there was this massive crowding where you could see the lingual aspect of the lower canine. And then we have beautiful alignment. Incisal edges were restored with a little bit of composite. So this is something I really recommend for, especially for every orthodontist, to learn how to do composite. This makes such a huge difference. And even if you do not want to do composite ever in your practice, it doesn't matter, because what it does is it teaches you how teeth really look like. And of course, we're dentists, we think we know what they look like, but actually there's so much to learn about the shape of incisors that helps you do really nice finishing touches, polishing the edges, and getting the best possible finishing. So what I want to transmit in this case is pure extrusion is very difficult for aligners. Actually, it's not even possible. If you only know one thing about aligners, this should be aligners cannot pull, aligners push. If you plan your treatments on that, or your biomechanics on that principle, you get probably 90% right. So pure extrusion is a pulling movement, and there's no chance the aligner can pull the tooth. So this is why we need to transform the pulling movement into a pushing movement. And one way of doing that is by pushing the crown backward. So like this, we get an extrusion by changing the inclination of the tooth. So this works best if we have proclined incisors. We just need to retrocline them to get the extrusion, the relative extrusion, and a good final inclination. So this again is easy. It's a crown tipping movement, and this is really easy. We do not necessarily need an attachment for that. However, you want to be sure you can place a gingival beveled attachments. This will support the relative extrusion movement. So pure extrusion needs an elastic. Relative extrusion can be done with the aligner alone. And this is the final picture. And the change is really huge. So he has now a full mouth smile. He has a nice smile arc. His head is still a little bit tilted to the back. And we were also able to improve the profile. Here's the before and after, and the change is really dramatically. And this is so rewarding about our job, that patients come to us with the desire to improve their smile, and week by week, they see the progress, especially with aligners. They really see the progress, and they are so happy and thankful. And for me, this is really the reason why I love to go to the practice every day, because we can give so much joy to our patients. Here's the panoramic X-ray. We have nice parallelism in the upper jaw of the roots. Wisdom teeth were extracted. This is important. Whenever we distalize, make sure that the wisdom teeth are gone, so we have the space to distalize. And the cephalometric X-ray before and after. So before, we have this proclined incisors, and after treatment, the inclination was improved. When you look at the left ceph, looks like the airway is very constricted. However, it's difficult to judge that on a ceph. But when we look at the cephalometric X-ray afterwards, looks a lot bigger. So whenever the patient presents with those assets, like the tongue is between the teeth, the head is a little bit tilted backwards, so that could be because they want to increase the airway. They want to move the jaw forward to increase the airway. This is when I would ask, do an initial screening. So we've already reached the take-home message. There are 3 characteristics that are really crucial to create a great smile. It's the smile width, the smile arc, and the incisor display. So the smile width, we achieve that with expansion. Remember, with aligners, bodily expansion needs an attachment. Place a horizontal attachment for most effect. The smile arc is formed by the incisal edges of maxillary incisors, and it's a positive curvature that is parallel to the lower lip. Remember that this is seen as very attractive, and we should look for that in our treatment plans, in our design. Incisor display, we want to have 100% of incisor display, because this gives a very youthful appearance, and we want to set our patients up for good aging. So as the lip has less tension with age, We want to make sure we position the teeth where they're fully visible and not hide the teeth underneath the lips. Remember that relative extrusion is predictable, whereas pure extrusion will not work with aligners. This is when you need buttons and elastics to support the movement. I also want to briefly cover the fellowship in aligner orthodontics for those who want to take the next step in their aligner journey. This is a great way. It's a virtual residency, basically. You can take the course from the comfort of your home, and it's really designed to teach everything you need to know about aligners, so you can provide the best care to your patients. Here's the QR code, and you're also happy to contact me if you want to have more information about that.